Okay, so we started off campus. Some of you, it's end of the week, right? Make sure you do your clinical eval tool. So those of you that had it yesterday, finish it up today if you haven't already turned it in. If it's your rotate off week and you're not at off-campus clinical, you do not have to do anything in the clinical. It's only, did you go to sim or did you go off campus? So if it's your rotate off week, nothing going on, don't have to fill it out, okay? Same thing, APPE, when we get to that, nothing goes in the eval tool. It's already taken care of in the hours. You don't have to worry about it. Prep U chapter's coming up, Saunders questions. And then next week, Tuesday we'll do the open check-in class. You take it, you get full points. We're getting a baseline, and then we do have assignments based off of looking at your reports. I'll walk you through that. So first step is just take the open check. So know that we'll be doing that. And then Thursday is exam 1.
Is that the only thing we're going to do?
It is. Yeah, it's a 75 question, so it really takes the full time. But it's how much can I help get you getting into prepping for NCLEX. And so the open check is one of those exams where you answer the question, you move forward, you don't go backwards. So that'll be Tuesday. But again, you take it, you get full points Tuesday. Thursday's exam, class exams, you're able to flag, you're able to go back. Huh? You take it, get 4 points. Here's hoping, right? No, that one you get the score you earn. All right. And then I do have that breakdown in the module, but yeah. So we'll dig into hematologic conditions, non-cancerous today, and then we'll move into like leukemias on Thursday. But a lot of it really ties together. All right, you got your objectives for the week. And these are kind of the overarching non-cancerous hematological disorders that we're going to focus in on. As you did your ticket to class, anemias, what's our big issue here? What's out of whack? Red blood cells. And they are increased or decreased? Decreased red blood cells. And because of that, what's going to happen to my hemoglobin hematocrit? Yeah. Okay. Polycythemia. What's the big overarching out of whack thing? Increased red blood cells. And so hemoglobin hematocrit go hand in hand, so you can expect that those will also be elevated. Neutropenia, what's our big issue? Decrease in white blood cells, and specifically a lot of times we're talking about neutrophils. But we're thinking about white blood cells, and you might see in other places leukopenia, which is overall white blood cell is decreased. But neutropenia is what we're going to focus on and use when it comes to like tests and exams. And then thrombocytopenia, what's my big issue? Platelets. And they're up or down? Okay. So everything's down except for in polycythemia. And depending upon the type of cell that's abnormal, it's going to affect symptoms and our treatments, our risk factors, concerns. That all makes sense? Okay. So we'll break it down and walk through. I really like the truck analogy in the pre-class video. So here are nice, beefy, good, happy red blood cells ready to deliver oxygen. So anemias are broken down. I will trip one of these days. It will happen every semester without fail. Are broken down based off what is the cause, all right? And so I've kind of made it even slightly larger categories than what you might see otherwise. But the first one is I'm not making enough cells, or I'm lacking a certain building block. That means I'm not making as many cells, or the cells I'm making don't have as large of a storage space as they would otherwise. Does that make sense? So a big one is iron deficiency. B12 is another building block that's really key. Chronic kidney disease, we talked about that. Why is that going to cause fewer red blood cells? Decreased epoetin. And then aplastic, we're talking about there's an issue with the bone marrow itself. Okay. Blood loss, whether it's a slow or a massive bleed, is going to lead to a decrease in trucks, right? I'm losing them. You are going to see sometimes where they say blood loss, then because I'm losing cells, I have a lack of iron. So sometimes this gets looped under iron deficiency. Let's just not go down that track. Like, for your brains and trying to keep things straight, just go, I'm losing it, rather than I'm not making it. But know that because I'm losing it, I have less iron in my body, and then making it is hard. And then sickle cell is genetic, and it impacts how the hemoglobin is made and changes how those connections are in the red blood cell. So we'll dig into those a little bit more. Okay. And so you'll kind of see what I was alluding to, that blood loss, right, is a risk factor for iron deficiency. In general, either somebody's diet does not have what they need, building blocks for iron deficiency B12, they have absorption issues, that's really, or they're losing that item, like in blood loss. So with iron deficiency, then we're going to be working on how can I replace that in the diet, add it back in, right? We want to replace the building block. B12, either it's a diet issue, which I don't think that's even listed there, right? Or there's an absorption issue. So this is where our B12 gets absorbed in the GI tract. Intrinsic factor is what helps that to be absorbed. And so when you have like Crohn's, celiac disease, that impacts the intrinsic factor. And so then there's less absorption. Another way we put it is got like nice happy villi, and then in like a GI disorder they tend to have smaller surface area, and so issues with absorption there. Just age itself is going to impact that absorption, and then long-term like PPIs, decreasing gastric acid can start to change how we absorb our nutrients over time. Tracking with me? Okay. Aplastic, remember this is an issue where bone marrow itself. And so this can be an autoimmune issue, or because of exposure to chemicals that are impacting how that bone marrow functions, or because we're giving a treatment such as chemotherapy that then is suppressing that bone marrow, because chemotherapy decreases proliferation or the dividing of cells. And it targets things that rapidly divide, and our bone marrow is one of those areas. Okay. So how we treat an anemia depends upon what's causing the anemia. And so we have to do testing to try to look for that, and we'll get into that in a second here. For manifestations, if somebody has decreased red blood cells, which of these vital signs or assessment findings, which of these cues do you think would be consistent with somebody with anemia? Pale skin. High respiratory rate. Why would our respiratory rate go up? Yeah. So I still have the same orders for my cells for my Amazon Prime goodies, right? But I have fewer trucks to get it there. And so my brain is getting the message from my cells, hey, my delivery is late. And so one of the things we do to compensate is potentially breathe a little faster, try to get those orders in by getting more oxygen in. What else? Tired, fatigue. Yeah, our cells aren't getting what they need. What else shows up? Pulse. Which one? I've got 58, 72, 118. Okay. And why?
Your heart's pumping harder to get oxygen.
Yeah, another compensatory method. If I have fewer trucks, I can still make all of my Amazon deliveries by picking up the pace and speeding. If I get through those deliveries quickly, we can still make our orders. Anything else? How about, we've got SpO2 on there, 89, 91, 100, 99. Which ones would you expect of somebody with really low red blood cell count? 89, 91. Yeah. Because of that decreased carrying capacity, we might start seeing changes. Okay. So we talked about pulse, SpO2, respiratory rate. Any other symptoms on there? Yeah, a lot of times we a little cooler as our body vasoconstricts peripherally to try to keep deliveries at the core. Those are the most beloved customers, are the ones that are going to get their Amazon deliveries on time, and people that don't have Prime are going to wait a little bit longer. Keep up with that. Yeah. All right. So when we prioritize our nursing assessment, vital signs are definitely key. Level of consciousness is going to tell me about what?
Whether or not you're perfusing the brain.
Yeah, are we perfusing our brain well? Looking at skin, looking for energy levels. Are you tired? Were you able to walk back to the exam room all right? Numbness, tingling, burning hands and feet can tell me about a B12 deficiency, can be a possible symptom. Watching our intake and output. And with that, talking about like, how's your diet, right? Assessing for signs of maybe I just am not taking in the right building blocks. And then labs, when we do labs for checking for anemia, we're going to target labs that are going to help us tell the reason. So you want a CBC, and then with that, they're going to look at some iron, folate, and B12 levels, because that's going to tell me, is it iron deficiency? Is it a B12 deficiency? What might be going on? Okay. All right. So some of the other disease processes that might come into play or be impacted, we talked about renal failure in our epoetin, right? Decreased erythropoietin is going to cause decreased production. Why would I be concerned with heart failure? How would that tie in? Somebody who's anemic. Yeah, so decreased perfusion, and Rob, you were saying?
Oh, it should be pumping perfusion.
Yeah, so I've got a pump perfusion problem, and now I also have a delivery via my red blood cell trucks perfusion problem. And so we're going to watch hemoglobin hematocrit levels and maybe need to transfuse sooner with somebody who also has a heart issue than somebody who has a healthy heart, okay? Start to see changes with temp regulation because of that vasoconstriction to compensate shutting down. May have an issue with immune function impacting, or if somebody has an infection, they're going to need increased oxygen supply, and if I'm anemic, harder to provide that, right? And then we talked about how our LOC is a sign of, do I have good blood flow, good oxygen getting to my brain? Okay. So how are we going to treat it? We're broken down kind of by the cause. So if, when we do those labs, my iron levels are low, that tells me, okay, we need more iron, right? And so looking at, do we need to increase iron in the diet? Vitamin C helps with absorption of iron. Iron also is better absorbed on an empty stomach, but it can make you a little nauseous. So that's where take your iron with a little bit of orange juice can be a way to less empty stomach, but still good absorption. If blood loss is the issue for why they're getting low on iron, we need to figure out where they're bleeding and stop it. Okay.
How much does an iron supplement or a diet increase your iron?
Depends on the person, because there's the absorption side too, right?
Okay.
So there's no cut and dry. But we're gonna recommend somebody increase, maybe take an iron supplement, and then look at what are you eating? What are some foods that are good sources of iron? Red meat, dark leafy greens.
All the things that we can't eat for the other diseases.
Right? And so then if you've got comorbid conditions, it can get a little bit rough. With the iron supplements, if it's a liquid, it can stain teeth. So I don't really often see somebody getting like a liquid iron supplement, but it's important for them to know that when they're taking it, being careful. We can also give like PO capsules. And how's it gonna look when it starts coming out the other end? Yeah, it can cause dark, tarry stools. Which is also a sign of what? GI bleed. So this is where it can get a little tough. If I've got somebody that's anemic because they have a GI bleed and now we're giving them iron supplements, how do we know, are they bleeding or not yet still, right? So, but definitely educating so somebody is aware. Your stools can get dark. Can also cause constipation. So making sure they're drinking plenty of water, that they're maybe need a stool softener, staying active, walking is going to help prevent that constipation, okay? Sometimes you'll also give like an IM iron injection. And have you guys heard about Z-Track method for IMs? Yeah. So if the iron leaks out, then it can also cause staining, kind of like with the teeth. And so Z-Track for IM iron injections is the best method. That's where you are kind of, when you're holding and stabilizing, you shift it so that when you pull the needle back out, it's going to shift back. And instead of having like a straight puncture, once that skin shifts back, the idea is it makes kind of a Z and it helps things not leak back out. Okay. If we're worried about signs and symptoms of bleeding, maybe that's the cause. We want to talk about how to watch for that. And GI bleed is pretty common, as well as menstrual, for common causes of like an iron deficiency for chronic. Okay. And then prenatal, sometimes we have issues with needing more blood supply, especially if somebody's anemic pre-baby. And so a lot of times recommending like an iron supplement here just to help. Okay. B12 now. Okay, another, I don't have the right building blocks. And then why? Is it that they're not taking it in their diet? Then we need to encourage them to increase that in their diet. What are some good sources of B12? Maybe we need to look it up. Supplements. So we might just take a vitamin.
It has a lot.
It does.
It has a lot of B12.
Right? Our B vitamins are how bioavailable, right?
Anthony says eggs.
Eggs. What else are you finding? Salmon. I want to say dark leafy greens as well. That's showing up for anybody.
Fermented food.
Tofu, fermented foods. So my tofu with my kimchi would be like awesome for this person, right? Okay. That's if you don't have it in your diet. You can take a vitamin. We can give it PO. You can drink your Monster that might have some cardiac effects. We're just not putting that in the mix, right? Get your salmon or tofu going. All right. And then folic acid is going to then impact absorption. What if I have pernicious anemia? This is where the intrinsic factor. I've written that down twice. Do you think it's important? Yeah. Knowing that link is an issue. So if it's a lack of intrinsic factor and I'm not able to absorb B12, is adding more to my diet and taking supplements going to fix the issue? No. Okay, so this is where you can give B12 injections. And those bypass the GI tract. So I don't need intrinsic factor to absorb it, and that's going to make it available for somebody. Okay. May need to look at how often are you using an antacid. Look at could like radiation, chemo be starting to impact or absorption depending upon where cancer is.
Is that the only solution for pernicious injection?
Yep, we have to bypass it. Or treating the cause, like if it's Crohn's disease, if we can decrease inflammation, get them more out of a flare, better absorption, they might do better with it in their diet. But you really have to bypass around and give it as a supplement, and oral's not going to work. Okay. If they're bleeding, slow the bleeding, stop the bleeding, and then I might need to do a blood transfusion. That makes sense? If it is to that extreme. And so it used to be our cutoff for giving a blood transfusion was 8 for the average person and 10 for somebody with cardiac. That's changed in the last 2 years. So some of the thoughts are that it's, we're seeing how there's a lot of risks to blood transfusions as well, and so we're trying to minimize that. When do we actually need it? But I would say more so, there's been huge shortages, right? Huge shortages in everything, and blood products is one of them. And so now a lot of times you're going to see this is now more 7 or even 6. And are they symptomatic? Like if they're low but they're not symptomatic, they might even hold off. But you're going to see lower and lower cutoffs, and it depends upon the institution, the provider, where that's at, for when we would give a blood transfusion.
And is it still tied to cardiac?
It's going down, but I'm kind of working with like clinical structures going, what are you seeing now? When are you waiting for? And it's been more 7 or 8, but they haven't told me like more specifically for somebody with cardiac. But no, I'm somebody with cardiac issues. If I have poor perfusion, smaller arteries on my heart, I've already got an issue with getting the oxygen to the important spots. And now I have fewer trucks delivering. So it's going to impact them sooner than somebody like you or I that's got a good, healthy heart and good perfusion. Okay? All right. So we're going to watch those lab values, see if they're going up, see if they're normalizing. Typically with like 1 unit of packed red blood cells or 1 unit of blood should raise my hemoglobin by 1. Okay, so if they're at 8 and I give them 2 units, I expect their hemoglobin is going to be pretty close to 10. If they're at 8, I give them 2 units and their hemoglobin comes back and it's 8.4. If they've been bleeding, I'm going to think they're still bleeding. We haven't fixed the leak. Okay?
You said 1 unit equals 1 lab value?
Yeah, for the hemoglobin. In general, like that's a rough estimation, but it gives you an idea what you should see. And this takes about like 4 hours after the transfusion's done before we're going to say that. So if they draw the blood for the test, and we just finished the transfusion, we're not going to see that increase yet. So that's where a lot of times you'll have an order like CBC 6 hours after transfusion complete. And that's what they're checking for, like how effective were those. And then we can watch our patient for their signs and symptoms, their vital signs. Are they still having to compensate? Or has their heart rate come back down? Is their breathing more regular? Just color. Somebody with a hemoglobin of 7 is going to be extremely pale. And if they have dark skin, where we're going to see that is nail beds and mucous membranes, membranes around the eyes is where you're going to see color changes more. Okay? So we can still assess that. Right. Sickle cell. This is our inherited disorder. Cells will actually shift from a nice little like donut type shape to more of a moon shape is why we call it sickle. They also have a much shorter lifespan for somebody with sickle cell disease. And so in regular red blood cells is 90 days. And this is going to be like more 14 to 30 day lifespan. for somebody with sickle cell disease. So I'm needing to make cells. What causes them to sickle is usually something that is causing I have a decrease in O2, or I'm needing more oxygen than what my body has, and that will actually cause the cells to shift. It is inherited, and we see it higher in our populations that come from places that have malaria. Because people that have sickle cell trait, that's sickled hemoglobin, malaria actually invades our red blood cells, and they're more resistant to malarial infection. And so what are some areas where you might see people that have higher rates of having this sickle cell trait? Africa.
Kenya.
Yeah. And then I would also say like Caribbean. And some of that is from malaria being present, and also because of that history of bringing folks from Africa to other areas as slaves. And so that genetic trait has traveled a little bit through the countries. Okay. And so here in the States, we're going to say our African Americans are going to have higher prevalence of sickle cell. And so, but when we're talking about genetics, you have to have two genes. It has to be homozygous, if we go back to patho, to have the disease. But if I have one unaffected gene and one affected gene, then you're considered a carrier. So in this example, we have a carrier mother, a carrier father. Now they'll have slightly different hemoglobin. It will show up, but they aren't going to have cells that can sickle. So we call them somebody that has trait versus somebody that is affected and has disease is going to have two of those. Okay. So those cells are really fragile. They tend to break down. They also tend to clump up in the blood vessels. I think that's my next cell. And then cause occlusion. So not only do I have fewer cells, less oxygen carrying capacities, now I'm blocking blood flow as well. And so that's what we're going to see when somebody goes into a sickle cell crisis. Something has prompted their cells to sickle, and now they're starting to have little occlusions throughout their body, and that causes a lot of pain due to the ischemia. Okay. So when we're managing somebody with sickle cell, we want to manage the anemia. We might do some blood transfusions. But then we're also managing occlusion, and I would say with that, pain. Okay, so we need to give fluids. You're gonna give high doses of IV fluid, and the idea is that if we increase the volume of fluid, it will help those sickled cells not to become as blocked and help them be able to get through the blood vessels. So increase in perfusion. And then we're gonna give usually some IV narcotic pain, because somebody's gonna have extreme pain. They're also going to be a risk for occlusion. And so depending upon where that blocked blood flow is, we're gonna start seeing other issues. What if that blood flow becomes blocked in somebody's brain? Stroke. Okay. What if it becomes blocked to an area in my foot? What happens to that tissue? Necrosis. So then what am I going to see? Ulcers. Breakdown of the tissue. Hopefully we won't get to gangrene. All right. What if those sickle cells are becoming blocked in the capillaries in my lungs? you're going to start seeing respiratory issues. And so they talk about like severe lung compromise. And so not only do I have poor perfusion, lung tissue dying, I also have those cells aren't getting where they need to do to the alveoli to have that gas exchange. So we could have some severe lung issues, and somebody might even need to be on a ventilator because of that. So those are some of the things we're watching for, monitoring for. Because we have such a massive breakdown in those sickled cells, we're going to have an increase of what in my bloodstream? Bilirubin. And then that can build up, leading to jaundice. And so what am I going to see with jaundice? Yep, yellowing, and you're going to see it first in the eyes, and then you'll start seeing it in the skin as it becomes more severe. Okay. Hand-foot syndrome is because of those occlusions. A kiddo with sickle cell, it's going to affect their growth and development. So bilirubin, high bilirubin, yeah, light therapy gets used for that, especially in like babies. And then
But does it work for adults as well?
that's a very good question. I don't know. In theory, I feel like it should.
Yeah.
Yeah. So somebody's going to have a lot of pain, can have swelling in joints and extremities because of those vaso-occlusions. May have fever due to inflammation. But then infection can also be a trigger for a crisis. So I want to be assessing for infection itself as well. We'll be watching a CBC, looking at our liver functions, and our bilirubin is going to be really helpful, right? And then talking through how are they doing, how are they coping, what resources does somebody have, what triggers, I want to say that might be my next slide, and how can we reduce crises. Okay. So I touched on most of these, right? IV fluids. Why would I want to give them oxygen? Carrying less, fewer cells, so I want to increase what's available to make sure that those cells that are carrying oxygen are as fully loaded as possible, right? Because those red blood cells, they bind to O2, and if I just have some available, I might not fill up completely. Maybe I only start out 72% capacity. I want to make sure they're like as fully loaded as they can before they head out into the body. We are going to do pain medication. We might do antipyretic for fever, and then beyond that, supportive care, ventilation, open up anything that's blocked. If blocked flow happens to the bowel and now my bowel is ischemic, what's going to happen? You have a dead chunk of bowel in your body. Bowel resection, we got to take that part out. And so that's where we're kind of getting with supportive care message. Okay. We're going to do a lot of teaching. Okay. And what I said, triggers, usually it's something that increases need for oxygen. So infection, we have a higher metabolic state. We need more oxygen. Or respiratory infection could trigger somebody to go into a crisis. Extreme cold temperatures. This is not somebody that you want doing the polar bear plunge down in the canyon. Higher altitudes have lower oxygen compared to lower altitudes. So plains, hiking a tall mountain can be an issue. We want somebody to avoid becoming dehydrated. And overexertion stress can be another trigger, okay? We want them to stay active. We just don't want them to overextend. So I want them doing their regular exercise, but I wouldn't want this person running a marathon and becoming extremely dehydrated. That makes sense? Or I wouldn't want this person going from, I haven't exercised a day in my life, and now I'm going to go do this massive 60-minute workout. Starting slow, and slow regular activity is going to be good. Because of those increased oxygen needs, building up blood volume in pregnancy, higher risk of somebody having a crisis in pregnancy, risk of complications because of those cells signaling blocking blood flow to our baby as well. And so know that it's very high risk. May do a lot of counseling for preventing pregnancy, talking about risk. Is your partner a carrier? We might need to get that, be checking into that as far as thinking about family planning.
With the pregnancy one, did you say they're at a risk because of the increase of volume? Or?
Yeah, so mom, higher risk of having that crisis, having cells sickle and start blocking because of increased need for oxygen, that increase in blood volume. But then if those cells sickle and become blocked in the placenta, now I've got an issue to oxygen, nutrients getting to baby.
Okay.
So.
You educated, patient about
Mm-hmm. Yeah.
So I know high altitude, but then you get a pressurized
Can help. And so things they want to do if they are going to have air travel is staying really hydrated, because it also dehydrates you, right? How can we reduce that person's risk if they do need to travel by air? So I was listening to a podcast, and she was talking about a patient she had that came in to the ED. And so he was a truck driver. Wasn't from the area, was doing a long haul. And so long days, long hours in the truck, wasn't drinking a lot of fluid because you don't want to be stopping all the time at the rest stops to go pee. It was winter and had just recently gone through a high elevation pass, and then coming out of the pass went into crisis. Okay, so some of his triggers: dehydration, high altitude, cold, and then had a stressful job. And so was it just one? Probably a combo of all the things, but gets through the pass, starts having some trouble breathing, severe pain in the abdomen, and went to the ED, and it had caused a crisis. Okay. All right. Our goal is to improve somebody's quality of life by reducing the amount of times they're going into a crisis. Right? A lot of times these folks might end up in the hospital frequently or become a frequent flyer, and they're having lots of pain. So what could they get labeled as? Drug seeker. But they have a very legitimate reason for pain. Right? So keeping that in mind. So a lot of teaching is going to help with prevention. On the genetic side, if somebody has sickle cell disease, they really want to make sure they're not having kids with somebody who also has the disease or carries the trait. Because then they would have a 50-50 chance of somebody that has a trait of having their child have sickle cell disease. So then it's counseling of, maybe adoption is going to be a better option. My first husband carried the trait. We're dating. One of his questions, yes, any chance you're a sickle cell carrier? I have no idea. I'm very white, so probably not. But it came up because it was something that he wanted to make sure our kids wouldn't have sickle cell disease. He knew he had the trait. So my kids have a 50-50 chance of sickle cell trait. Wasn't first date, but it did come up fairly early on. Like, do I want to invest in this relationship? If you're a sickle cell carrier, it's out. But things that somebody needs to think about, right? And that's hard to know that anytime there's a genetic risk, thinking about, is this something I want to pass on? Or am I going to think about other options when it comes to kids? Or are we both going to get tested and find out, right? Okay, aplastic anemia. We've got a bone marrow issue, right? This is not, I don't have the building blocks. This is, the bone marrow itself is not functioning. Pretty equal across male and female. And typically we're going to see this where there's damage to the bone marrow. A lot of times there's like a chemical exposure, whether it's neonatal, in their job or environment, and this causes decreased production of red blood cells. Okay, so we're going to do the same sort of tests, iron level, CBC, right? We're going to make sure we know what's causing it. But if iron, B12 levels are all coming back great, then we got to keep looking. And so a bone marrow biopsy is going to be what really tells us, okay, the issue's in the bone marrow. Because our bone marrow is also dealing with platelets and white blood cells, we might also do a coagulation study to see if there's an impact on our platelets as well. Okay. Going to have the same sort of symptoms as anybody with anemia. The addition of, because we're impacting other cell growth often, may have a higher risk for infections, lower immune system, may have higher risk of bleeding. So this person we're talking about also might have some neutropenia or thrombocytopenia in the mix. Okay. Right. Because there's risk of bleeding, we want to protect from injury. So you might have somebody on bleeding precautions. We want to reduce infection risk on top of, hey, have good nutritional intake, talking about activity, balancing activity with rest. And then because the bone marrow itself is not making what we need, simple supplementation isn't going to work. So this person's going to need transfusions. Or we might use erythropoietin to try to stimulate the bone marrow to make more. Yeah.
Question was just like, what are some bleeding precautions that would be implemented?
I'm going to touch on that when we get to the thrombocytopenia. Yeah. Okay. So Neupogen, Epogen, this is what I'm talking about with, this is our supplemental erythropoietin. Also helpful in our chronic kidney disease patients, right? And then also could consider bone marrow transplant for this patient. Okay. How do we know it's working? Our blood count normalizes, or at least is moving in the right direction, and then we're not having infection, bleeding, oxygenation issues, right? Okay. I'm not gonna really test you on this one, but I think it's helpful. There's also a genetic deficiency called the glucose-6-phosphate dehydrogenase, or G6PD. So this causes premature breakdown of red blood cells because they're breaking down, issues with jaundice, and we're going to see the same anemia type symptoms, and then also enlarged spleen because of that breakdown of cells. Okay. Okay. Let's kind of put it together a little bit before we move into the others. So for anemias, what are some possible causes of red blood cell loss? Bleeding. What are some maybe common bleeding? Menstruation, and I think I heard GI. GI, trauma. Yeah. What are we gonna do? Stop the bleeding. This is gonna help for all of those except for menstruation. Replace blood, so we might need transfusion. And I talked about with bleeding, we have that link to iron deficiency. So what else might be good for an intervention? Yeah. What do we want to teach? Kind of depends upon what it is. Signs and symptoms. How are they going to know if they're maybe having a lower level and need to be checked out? Right? More fatigue, pale skin. If they see black tarry stools, right? If they're getting very fatigued, short of breath.
Iron-rich diet.
Talking about iron-rich diet. If there's maybe something we can do to prevent the bleeding. With trauma, maybe it's risky behaviors, talking about those, right? If it's GI, where adjusting diet might help.
Well, maybe with menstruation, it would be what kind of birth control they were on.
Yeah, maybe changing birth control. They can decrease, yeah. And then how are we going to know if they're getting better? How are we going to evaluate better? What are some cues for better?
The causes improve. Bleeding.
No bleeding. Color. So mucous membranes fade, more pink, right? Heart rate. BP, O2, yeah. What would be some signs that your patient's getting worse? Pale. So they're white or even grayish. Lightheaded. Yeah, maybe they are getting confused or forgetful.
Their vitals and out of whack, so
Heart rate's up. O2's down. Cap refill would be what? Greater than 3. All right. So red blood cell destruction, breakdown of those red blood cells. We're going to be talking more sickle cell or the G6, etc., where those cells are getting broken down or they're not as effective. What's the cause for these two? Genetic. Okay. What can we do?
radiation.
Radiation. What am I going to do for my sickle cell patient? Or my G6 patient? Pain meds. Fluids. Those cells are getting broken down. Yeah. Transfusion. What did you say, Emily?
I said transfusion.
Okay.
Will they ever need some sort of renal replacement therapy for clearing out stuff like bilirubin and all that? If you have a lot of the waste products and stuff.
Not necessarily to the point of like dialysis, but might need some support. The fluids are going to be huge, helping your body clear that. What are we going to teach somebody? Triggers. If it's genetic, what might come into play? Genetic counseling, yeah. Ultimately, that's choice, or talking about like making sure we're testing partner too, and or they know their risks. And then,
What a crisis.
yeah, what's a crisis? When do you need to come in? And because those are getting broke down, maybe what does jaundice look like? And that would be something to come in and get checked out for. Okay. How are we going to evaluate? What are cues that they're doing better? Decreased pain. Skin color. Yeah, let's see. A lot of these are going to be really similar. Skin. Vitals. I think skin and vital signs is going to cross all of this, right? If we're trying to prevent crisis, what can we track that tells us we're doing it better? Decreased crises, decreased admissions to the hospital. What's going to tell me they're doing worse? Increased pain. What's going to tell me about jaundice?
You first notice it, it's clear,
Yeah, they're going to be yellow. They're bilirubin. I can watch that level, right? Shortness of breath. Or start seeing signs and symptoms of tissue damage. Right? All right. Hypoproliferative. This is my bone marrow, right? And we'll just do like the highlight reel as we go through this one. What's the cause? Chemical. Some sort of damage to marrow. Whether it's radiation, chemical.
So radiation wouldn't destroy the red blood cells without it being like, so it would be like a hemolytic. I don't know where radiation, I thought radiation was.
Depends on where the radiation is. But with destructive, and we're talking about like the genetic, where those cells are breaking down. Yeah. What are we going to do? I could do a bone marrow transplant. What else? Transfusions. Yeah, EPO. Try to stimulate it. Okay. What teaching do we want to do? Signs and symptoms, infection prevention. Yeah, and bleeding, which we haven't covered yet, but we are going to. Talking about bleeding risk. Right. Same thing, we're gonna monitor our labs. Increased red blood cells, increased hemoglobin hematocrit tells me that we're doing better. Right. Our labs, our signs and symptoms, the color of their skin. Symptoms such as short of breath, fatigue, are all going to be helpful.
With the coagulation study being evaluation, or would that be?
Yeah, so this one is where like the coag could be helpful, along with just a CBC. Tell me more about platelets. Yeah. Awesome. Kind of pulling it together. Okay. Quick stretch break. If you need to go to the bathroom, this is a good time. But we'll kind of dig in. If you want to go into the module, there is a case study chart. Tell me if it's not showing up and I will fix it. But we are going to pop into this case study and talk through it a little bit. And work on a plan of care, because I also want to prep you for what are you doing with your plan of care every week off campus. So you may find it helpful to have that case study chart up. I'm relying on your eyes to pull out the info then as we're building our plan of care. So I'm going to give just a minute or two for our bathroom folks, and then we'll keep going. Now we are. Okay, thank you. So we'll zoom out so you guys can see it on the recording. But this is how specific you need to get on your care plans. Take what did I assess? What am I finding in my patient's chart? And start plugging it in. Okay? Overarching, looking at this, how are these connected? Is anything causing maybe helping to cause that perfusion issue? Chronic kidney disease. We have, maybe there's, with chronic kidney disease, some decreased erythropoietin, so decreased stimulation. Would decreased perfusion also affect my chronic kidney disease? Okay, so double arrow. All right. Anything else causing perfusion? Calcium. And so we talked about calcium. We talked about 25% of his meal. He's a widower, so what is he eating at home? So nutrition, if I have poor iron, B12, folate intake, could cause anemia. What else? I'm hearing it. You're starting to think.
Perfusion, impaired O2 and COVID.
Yeah, because I have impaired O2,
I'd also say COVID.
it's carrying. That could cause depression, fatigue. How am I coping? I don't have energy to make the meal that I want to because I'm tired. Is coping maybe connected to my nutrition? If I've got poor coping.
You eat bad.
Huh?
You eat bad when you're depressed.
You eat bad when you're depressed. Yeah. You don't feel like making a nice meal. And it's hard cooking for one, right? Compared to cooking for a couple people. So even if he was the one that cooked in their relationship in his marriage, maybe he doesn't feel like it anymore. Okay. Is paired oxygen going to impact our kidneys? Okay. So this is where on your care plans each week while you're off campus, start connecting them. How are these problems related? Is one leading to the other? And I would suggest you do this as part of how do I prioritize them, right? And so maybe it's the thing that's causing the most issues. Maybe it's my ABCs, right? And in ABCs, perfusion and oxygenation are probably going to be my top two. And this is where looking at their specific SATs, where are they at in the moment, what's the top priority might change, or what's the root cause might help infer which is going to be my top priority. What do you think for this guy? Perfusion or Imperito 2? What's top priority? They're both high. Don't get me wrong.
I would think almost O2 because when someone's anemic, normally it's lower, the oxygen's lower than what it's showing.
Yeah. So what's causing the decreased oxygen at the cellular level? Carrying capacity. So if I fix the perfusion issue, let's turn it on slowly. Yeah, and right now his SATs are maintaining with our treatment. If his SATs were 85%, that might bump up and become 1. Right now we're at 95%, so it's not as critical as fix the perfusion that's then going to trickle down, right? And also thinking through, like, what can I intervene on quickly, easily, right? How would you go down the next? So chronic kidney disease, nutrition, or coping. What's third? Again, these might shift through the day as you get more information. Hearing, nutrition.
But the CKD is not,
My kidneys are going to impact.
Yeah, but
you can't heal that, but you can heal underlying problems that make that. Right.
Good thoughts.
you
Can't fix it. It's chronic. It doesn't come back. I can just keep it from getting worse.
But elimination's pretty important.
The elimination's pretty important. So this is where looking at, do we have fluid issues? Is he retaining, overloaded? Do we have electrolyte issues? And maybe that's my problem over CKD and might affect where they're at. How's my BUN creatinine? Is it high but not critical? That might be down more than, oh, are we in stage renal failure? Super high, lots of elimination, electrolyte issues. That's going to bump up in importance.
So on our plan of care, do you want us to label like our number 1 issue, 2, or 3?
Yep,
Okay.
so where that little pound sign is, I want you to start putting these in. I think I'm hearing more arguments for nutrition being next. Okay. And maybe we use Maslow's a little bit and say, well, chronic kidney disease is 4 and coping, even though it's affecting a lot of things, is 5. The kidney disease, the coping, those are not going to be quick fixes. They're going to take some time. Yeah. / we can't completely fix chronic kidney disease. So those types of things are filters you can use as you're thinking through, how am I going to rate these problems for my patient today? Okay. And then you'll move into, what am I going to do for it, right? And let's just do perfusion. Right? And the perfusion's really, like, it's anemia. Depending upon, am I using medical diagnosis? Am I using concepts? What works for your brain? What's our goal for this guy? I want him to feel less fatigued. So how could I measure that? Patient will. When is he feeling shortness of breath and fatigue? Okay, so maybe he can walk to bathroom and back without shortness of breath. Sound fair?
Mm-hmm.
Specific. Timeliness, maybe I need to say by tomorrow, by end of shift, but thinking through my interventions and when are they going to actually start taking effect. Is he getting a transfusion this morning? And maybe end of the shift does totally make sense. Is it going to be long-term iron replacement in more of a while? Maybe we don't have a transfusion today. I might need a time that's a little farther out. What are we doing? What do you think is going to happen for this patient? I gave one of them away that would be helpful. So O2, PRN. Yep. What else? Iron. What else? Transfuse. 1 unit packed red blood cells. So maybe our interventions overlap a little bit. Can I do something with diet? Eat 50% instead of 25%. Right? Anything else you want to do for his anemia? This one's hard because it's not as quick fix compared to packed red blood cells. Hydration. How are we going to evaluate? This needs to go back to what's my SMART goal? He can walk without shortness of breath. So what are we really using for evaluating it? Patient report. If I had patient will maintain SATs above a certain amount, then I would say SpO2. Yeah. What am I using to measure this? Patient report after walking. And then, so he gets up, he does well walking to the bathroom, but then on the way back is a little huffing and puffing a little bit. How would we evaluate our goal? Partially met. And then I could say to bathroom, okay, back, short of breath.
So even if they don't meet the goal, it's still okay?
Yeah.
Okay.
Yeah. There's a reason not met and partially are there. We don't meet all our goals for our patients. Or sometimes we're working on something and they have a complication and we just spiral another direction. And so it's more, are you able to, I want to know, can you evaluate it and can you explain or think through why? Because this is the things as nurses we're doing in our heads all the time, but it's in the background. So this is just giving you a framework to show that, to think through it, and then also to help your clinical instructors evaluate.
We had one yesterday with my nurse. We were watching the trends of her blood glucose. It was constantly low at time. And she was like, if she didn't want to eat most of the time. So she's like, at least if I can just give her some juice. And she gave her juice in the morning, and by the afternoon it raised by 10.
Yeah.
So it was a little bit better.
Yeah. And so depending upon what was my goal, I might be partially met. We were able to get it here, but we still got some more work to go. Yeah. Okay. So we've got a few minutes to get through our last disease processes, but I think because we spent so much time on anemia, it's going to make more sense. So polycythemia, opposite of anemia. Now we have too much red blood cells, okay? And so this can either be primary, my body is just making too much, so this is an issue in the bone marrow. Where's my highlighter? Right? Or it can be secondary. Secondary, think about dehydration. All the counts go up because there's a greater percentage per blood volume. Okay. We also can see polycythemia if somebody lives at a higher altitude, because our body adapts, our body adjusts. And so this is why athletes will train at higher altitudes because their bodies will create more red blood cells to be able to carry the oxygen. There's less oxygen in the air. And then when they go down to a lower altitude, they're like, oh yeah, I got this.
Almost like cheating.
Almost. Right? So because of those increased cells, we see splenomegaly. When that increase becomes severe, like very high levels, it kind of doesn't make sense. You're like, but why are they short of breath? They have plenty of cells. Cells actually start to get congested and backed up. It's too much. Too many trucks on the road. Think about like the freeway, and you're trying to get somewhere in Portland, and it's just backed up. All right. And they're going to notice that shortness of breath, difficulty breathing more when lying flat. May have headache, dizziness, or even weakness. We're going to use our CBC. We're going to see what is elevated. You got this. Red blood cells. And then we're going to do a bone marrow test, biopsy, genetic testing, if we don't think it's dehydration, to determine, like, is this really like a primary polycythemia? Why are they creating more? May start with fluids if you think they're dehydrated, and see, okay, does that filter and normalize our levels? Okay. If it's just a mild elevation, people probably will not be symptomatic, right? My athlete might want it and be doing really well. But otherwise, we're going to treat the underlying cause, figuring out what's going on. Is it the bone marrow? Do we need to be doing something such as chemo and radiation to affect that bone marrow? The other thing we'll do is what's called therapeutic phlebotomy. This is just like giving blood. They're going to take off a pint of blood when needed to help decrease and normalize that cell levels. So this would be used when they're symptomatic. Okay. Because everything's blocked up, we have issues with thrombosis. Sometimes because somebody has a bone marrow issue, it could be affecting platelet count, and they might have bleeding. So it's not really the red blood cells, but it's the bone marrow issue. It's getting us there. Thrombosis, clotting, think too many cells. Okay. So they're going to need to come in and have their CBC count checked periodically. And depending upon how they're doing, could be monthly, it could be every 3 months. We want to encourage them to drink plenty of fluids, to rest. Elevating lower extremities when sitting might help with what? Clot risk. Help with blood flow, perfusion. And then because I have risk with clots, we want to be really checking for any issues with heart problems. Might need like a baby aspirin to help prevent clotting. Okay. So we want to teach them about signs and symptoms of blood clots, be it like DVT, heart, stroke. Make sense? Why do they need to drink a lot of fluids? Your blood is super concentrated. It can get blocked, stuffed up. May need to have smaller, more frequent meals just for comfort because of the enlarged spleen. Tight restrictive clothing could be a risk for blood clots, impact flow. Extreme temperatures can kind of be a trigger for issues. We want them to have routine exercise, be active, that heart side. And we already talked about blood tests and genetics. Okay. How do we know they're doing better or treatment's effective? They're not having clots. they're not having bleedings, their red blood cell count normalizes. Symptoms, if they're having trouble laying flat and breathing, they can now lay flat and breathe. Okay. Thrombocytopenia, what is it? Low platelet count. Okay. This could be caused by cancer, infection. This is where like DIC comes in. Oh, DIC is down there. Medications can impact clotting, and chemo is one of them. And then some autoimmune conditions. DIC is what happens with severe inflammation, with infection like sepsis. Might ring a bell from patho. Okay. So similar to polycythemia, we could have like a genetic idiopathic side. You can also have this happen after a viral infection or immunization because our inflammatory response to that, platelets might get used up. Heparin, some people have we call it HIT, but in response to receiving heparin, they'll suddenly start showing bruising, and so that can be a factor. And then hemophilia really isn't low platelets, it's other clotting factors that are going to impact our clotting. Where I really want you to focus in on is having the low platelets, and I would say out of these are more important. Okay. So you might see bruising, might just barely bump something and suddenly have this big bruise the next day. Same ways we monitored everything else, hematologically wise, same kind of monitoring. Okay. DIC, how much do you guys remember from patho? I want to really dig in. Clotting cascades gets activated. Microclots then cause ischemia. And then all the platelets and clotting factors got used up, so now I have bleeding issues. So it's too much clotting causing bleeding. That's like the really bendy thing in the mind, okay? And with that, our platelets, our fibrin levels, this is maybe like the not great feeling from patho going, oh, I remember that question on that exam. I'll go low, my D-dimer goes up, my fibrin degradation products goes up because I'm breaking more clots down, okay? Really, where we're going to see this is a lot with sepsis. That's my big takeaway, I think. Platelets get used up, clotting issues, bleeding issues, and there's usually some infection or think about recent viral, something going on, okay? So bleeding precautions, I think is the most important thing I want to make sure we cover before we end today. When we have somebody on bleeding precautions, we want to prevent falls, right? Am I going to want them to use an electric razor or a disposable razor? Electric. At home, I want to do fall prevention techniques because if somebody is going to bleed easily, do I want them to fall and hit their head? No, it's going to cause more damage, more issues. So talking about rugs. Here's one that shows up on like NCLEX type questions sometimes. For somebody on bleeding precautions, do we want them to use a sharp knife, a average knife when cutting up veggies? What do you think? Sharp is less likely to like move and shift and hit fingers. So that's the one that sharp knives on bleeding precautions is a good thing because you're less likely to actually cut yourself. which is weird because it's going to cut easily versus something that's dull. I'm going to put more pressure, and sometimes they shift. So that's the one that I don't think totally makes sense when I see it on exam questions. So I want to highlight sharp knife is good with bleeding precautions because they're going to cut easier or less cut themselves, as long as they're not really trying to cut themselves, right? Constipation can cause some issues with bleeding at the anus. So I don't want them to be constipated. It's like, how do I talk about this in a good way? Let's just put it out there. So you might want them on a stool softener. Along with those, anal membranes, also vaginal membranes, are more fragile. So when platelet levels are extremely low, talking about safe sex, maybe avoiding it until platelet levels have come back up, okay? And they're going to need to have frequent lab tests so we can check on them and see where they're at. If they notice blood in their stool, if they have a nosebleed that's just not stopping, they need to come in. Right? And we want to minimize like automatic cuffs going off because it's more likely to cause bruising for this person. Might want to go in and do a manual or not have an on-list like auto thing going on every 15 minutes or anything like that. Might want to change from IM injections to another alternative method of giving a medication because of bleeding risk. Okay? So that's for like low platelets in general. If I have somebody go into DIC, I need to monitor their vital signs closely. We need to watch their blood test that tells me about how are their organs doing. If their liver panel starts going up, their kidneys start going up, I'm worried about those organs are starting to shut down. Cryoprecipitate. So sometimes we give FFP, fresh frozen plasma, has all those clotting factors. So you may see that, transfuse FFP. Cryoprecipitate is like FFP on steroids. It's spun down until it's like ultra concentrated. Either of those could show up on a test, okay? We're going to be monitoring their I's and O's, watching for bleeding, being really careful when we're moving them. We need to make sure we're repositioning, but being careful through that. Protecting their skin. If they've got an NG tube, if they've got an ET tube going down their throat, really watching that because just that mild tube moving around could cause bleeding, okay? You may see this person have blood thinners because of the microclots, or they may not because of the bleeding. This is one of those things that's kind of very individualized to the patient and can be controversial of do we give blood thinners or do we not give blood thinners. When we get to this stage, somebody's at high risk for mortality. So they're coping and maybe I'm switching to working with family like in the ICU setting. Okay. We don't want them to bleed out. End of story. Simple.